Dr. Hoover, you may proceed, and then after Dr. Hoover, we are going to go to questions of the witnesses. Thank you very much. Make sure that Dr. Hoover's microphone is on. Want to test that?
All right. I'm Bob Hoover. I'm the Director of the Epidemiology and Biostatistics Program at the National Cancer Institute, and I'll be talking briefly about the scientific evidence on the topic of cell phones and risk of brain cancer. While as an epidemiologist I'll be focusing today on studies of risk in human populations, it is also important to note that on the biologic side, radio frequency radiation from cell phones is billions of times lower than the energy of X-ray photons. As such, its effect on the body, at least at this time, appears to be insufficient to produce genetic damage typically associated with developing cancer. Alternative mechanisms have been suggested, but to date, no alternative mechanism of how this exposure might result in cancer has been vetted adequately. From the epidemiologic side, descriptive data from the large network of population-based tumor registries funded by the National Cancer Institute reveal that there has been no increase in the incidence of brain or other nervous system cancers from 1987 through 2005, a time period when cell phone use increased by about tenfold. From the analytics side, the earliest analytic epidemiologic studies, including one conducted by the National Cancer Institute, self-reported frequency and patterns of cell phone use were compared between patients diagnosed with brain or nervous system tumors, known as cases, and patients or controls with other diseases, an investigation known as a case control study. These studies found no convincing evidence of association between cell phone use and glioma, a malignant tumor of the brain, or from an angioma or acoustic neuroma, two largely benign tumors of the nervous system. These early studies pointed out that future investigations would be needed to evaluate potential effect of long-term use as well as changing cell phone technology. As a result, a new generation of cell phone studies is emerging. However, brain cancer is a very difficult disease to study well epidemiologically. Much of the disease is rapidly fatal, and the tumor and its treatment can impair cognitive function. Cases may cooperate at different rates than controls, and answers to questions may be altered in someone who knows they have a specific condition. Given all of this, it is not surprising that there is a fair amount of inconsistency within and between many of these studies, both in quality and in findings. Because of this, I'll focus only on the larger and better designed of these studies. Perhaps the most notable of these is a large collaborative project that includes individual studies from 13 countries, collectively known as Interphone. Analyses of data from individual centers and those pooled from some but not all of the individual countries have been published. These individual studies have found no evidence of an overall increase in the risk of any type of brain tumors associated with the first 10 years of cell phone use. In addition, no increased risk has been found in relation to several measures of exposure, including time since first use, lifetime years of use, the number of calls, the hours of use, and the use of analog versus digital phones. A somewhat increased risk has been found in some studies for tumors diagnosed on the same side of the head the cell phone was used for those with more than 10 years of cell phone use. But these are based on small numbers, generally less than 5% of the cases under study, and are not consistently seen across all the studies. Many of us are hopeful that the combined Interphone analysis, including all the centers in the original study, which is now underway, will provide a much larger number of long-term users, which will allow an evaluation of different exposure metrics and latency, a formal assessment of the consistency in study-specific results, and more comprehensive and statistically stable estimates. This could bring some clarity to the current state of the science. In another noteworthy study, Danish investigators followed up cell phone subscribers over time and found no increased risk of brain tumors among the subscribers. This type of study, called a prospective study, has the advantage of not having to rely on people's ability to remember their past cell phone use, which could be inaccurate or biased. We do know that cell phone use is increasing rapidly among children and adolescents. They are a potentially sensitive group because of their small head size and could result in higher radio frequency exposure, and the young brain may be more sensitive. To date, there are no published studies in the peer-reviewed literature regarding the risk of cancer and cell phone use in children. However, there are ongoing studies in Europe that will soon provide information on the risk from cell phone use among children. In summary, then, thus far, brain cancer incidence trends in the U.S. are unrelated to patterns of cell phone use. Most analytic studies indicate no overall increased risk of brain tumors within the first 10 years. There are inconsistent findings of increased risk across many different ways of measuring increased dose. There are some isolated findings of increased risk in some dose and population subgroups, but larger studies and replication in different study designs are needed to sort out the roles of chance and bias from those findings that are really worth pursuing. Potential risks associated with childhood exposure have not been assessed. Insight into these last 2 points may come relatively soon from ongoing analyses of the overall Interphone study and from the Northern European Case Control Study of Childhood Cancer. I thank you for the opportunity to present and look forward to your questions.
I thank you, Dr. Hoover. I want to thank each of the witnesses. We're going to go to questions from members. I would like to begin by asking the scientists who are here